Thanks so much for joining me today. We're going to talk a little bit about Chiari and syringomyelia and how it affects brain development. And just for the crowd here, do you mind just introducing yourself for a moment?
Sure. So I'm Jarod Roland. I'm a pediatric neurosurgeon here at WashU University in St. Louis. And I, of course, take care of the full gamut of pediatric neurosurgery. And when I'm not doing that for my day job, I'm doing research with functional imaging or intracranial electrophysiology, and specifically here, doing that with patients with Chiari Malformation.
Great. And you're involved in this project. We're really sort of trying to kind of go back and redefine Chiari and understand how it affects brain function, development, and how patients do, right? How did you first get interested in this particular disorder, and tell us a little bit how you came to think about this from a scientific standpoint.
Yeah, so for me, I think it all kind of led from my interest in pediatric neurosurgery, and Chiari Malformations is a pretty common condition that we see in our patients. It's an interesting one because it's specifically a structural abnormality that we don't fully understand why it causes the symptoms that it causes. As I was coming through my kind of realization of what I wanted to do and the things that I was interested in, one of the things that I kind of realized is we, as pediatric neurosurgeons, spend a lot of time in the posterior fossa, whether it's for brain tumors or Chiari Malformation or whatever that might be. Along that same timeline, we were learning more and more about the cerebellum. One of our co-project leads had published a big paper on some of the functional connectivity of the cerebellum. And at the same time, I was learning from Dave Limbrick here about what a Chiari Malformation is and how that affects patients, and the big gap in knowledge that we knew about that condition in the cerebellum. As all those things kind of came together, we started to realize that there's a real opportunity for studying that patient population, that particular condition, and the cerebellum. And that's how all this kind of came to be.
I love the term that you use, precision cerebellar mapping. Can you tell us a little bit about how that's accomplished and what the technology is and the skill set in order to understand that particular application?
Absolutely. So to understand what that means, it kind of helps to understand what we're comparing it to. So a lot of things in the functional imaging world were previously done at a large scale with large populations of individuals, group them all together, average all their data together. And by doing so, you get a large signal with smooth data and average out a lot of the noise. The problem with that is you get to understand how the brains work on average by grouping hundreds and sometimes even thousands of people together. You understand on average what that means. But that's not how we practice medicine. We don't practice medicine on groups of 1,000 people at a time. We practice medicine on individuals. And so that's where a new technique or an innovation in the technology to study not only group average maps, but individual maps, and individual maps with great precision. It turns out that took a lot of technical work. Some of that was pioneered by the people here, a lot of people on this study, but that's what allowed us to better understand with great precision the specific areas, the specific connectivity in all the different regions of the brain, including how the cerebellum and its connectivity with the cerebrum, the kind of larger part of the brain, how that works on an individual basis.
So take us through it a little bit. How do you actually perform this and map the cerebellum? What does it look like to a patient, for example?
So for me, the way I'm usually talking about most things, specifically for this project, I'm talking about mapping specifically with resting state functional imaging, functional MRI. There's a lot of different ways you can talk about mapping. There's a lot of different type of connectivity metrics you can use. Here we focus on resting state functional MRI. There's a variety of reasons for that. There's a significant advantage to being able to tell a patient, I don't need to put you through a lot of tasks. I don't need to have you do a lot of complex calculations in an MRI scanner. All I need you to do is sit pretty still as you possibly can, keep your eyes open, and try not to fall asleep. That's the task. And that's what we call resting state fMRI. And it turns out if you can do that, you can understand a lot of the network level organization of the brain throughout the entire brain all at once. Again, I kind of contrast that to what we call task fMRI, which is a little more traditional way of doing functional imaging. And that requires you to do a specific task. And that gives you a better contrast for that specific task, whether it's opening and closing your hand. I can map very specifically where that hand part of your motor cortex might be. If I have you think about math calculations, I might be able to map out where in your brain you're doing your math calculations. But I can only do those things one specific task at a time. And with resting state, I can get a whole brain analysis of multiple networks with just one image acquisition. So that's the way we take that on in our research for this population here. And there's a lot of technical nuance to it, but the long story short is there's a lot of digital signal processing that goes in to define those networks and compare those networks across individuals, those with Chiari malformation, those without Chiari malformation. And it also assigns specific networks that have been well described in the literature, well described by all those other types of techniques that I described, task fMRI and other things, to better understand what those networks mean, what kind of cognitive functions they relate to, how they relate to a patient's symptoms, and all those other factors that we're so interested in.
Sort of on that, so you have this advanced MRI scan that looks just like any other MRI scan, but patients are sitting in there, and while they're resting, awake, eyes open, their brain is sort of being mapped, not in real time, but when you come back and analyze it over time, right?
That's right.
Tell us a little bit about how you're relating that to function, meaning how a patient's doing, if they have symptoms, if they're how their brain's developing, and then maybe related to that, if somebody does have a Chiari malformation, what kind of information can this scan give you about how their symptoms may or may not relate to that Chiari?
Yeah. So I think that's the crux of the question for this research. And there's a couple different ways of going about it, a couple of different ways that we're going about it. One is we have some a priori information about these various networks. Sometimes we'll use the term canonical networks, resting state networks that have been previously described, previously correlated to other types of functions. So one common example that was some of the early work was done here, pioneered here, is called the default mode network. There's a few other networks like the frontal-parietal network. Some of these have to do with things like attention or executive function, and the strength of the connectivity and the organization of those networks might be altered in people who have dysfunction in some of those type of higher order cognitive abilities. That was certainly some of the things that we've seen in Chiari malformation is occasionally there are these type of complaints that we didn't understand very well how they relate to the cerebellum. And our hypothesis is that some of the network level organization might be altered in patients with Chiari malformation compared to others. So we have that hypothesis, and so that's one of the things that we are aiming to study is those specific networks, are those affected, are those altered in patients with Chiari malformation compared to others? And then the other thing that we're doing is in subjects we're able to enroll, getting other type of cognitive testing to see if we can hash out, quantify some of those complaints, some of those concerns, maybe some of those cognitive deficits, and use those as a correlate to the functional connectivity to hopefully tie those two in a more quantitative, kind of more robust manner. The goal, of course, is if we can do that, if we can correlate those things and have a stronger signal straight from imaging, not have to put someone through all that cognitive testing, hopefully it'll help us tie that relationship of what's causing those cognitive symptoms and be able to predict who will benefit from intervention better than what we have today.
Thanks. That makes a lot of sense. One thing that would come up is, both of us treat both children and young adults and that sort of thing. Is it just one set of tests that kind of go across the lifetime, or are you planning on scanning young children, adults, so forth? What's it look like in terms of the lifespan or the age range?
Yeah, it's a very good question, a very important question. There's a variety of things outside of even just our study that's aiming to address that right now. One of the big studies that came out of WashU was the Human Connectome Project. It really changed the way a lot of research is done. It impacted the types of imaging studies that we're doing in this project. But one of the things that followed out of that were a variety of extensions to that same project in young development and elderly development across that timeline to better understand that exact question. For us specifically with Chiari malformations, we're doing a couple of things to kind of address that. Is one, we're doing more longitudinal imaging as opposed to kind of cross-sectional imaging. So for instance, the Human Connectome Project was largely cross-sectional. A lot of the studies prior to the recent maybe 5 or 6 years were largely cross-sectional studies. And that's one of the things that we've realized is the more you can do longitudinal within subject comparison, you get a lot greater power, because you also help avoid those complications of, well, how does a 5-year-old compare to a 10-year-old compare to a 45-year-old if you're able to compare within subject longitudinally. So that's one way that we're addressing that, but we're also aiming to try to capture the breadth of our clinical population as best we can. The older and older we get, certainly other aspects, other parts of aging will likely affect all those functional connectivity measures. And certainly in our very young population, just throughout development, we know that changes. It makes it a little bit difficult when we get really young for some of our patients to tolerate an MRI scan. So that's a challenge, but it's a challenge that we're taking on. We think we have all the necessary skills to recruit some very, very young patients with a lot of special attention. But certainly that age range from 9 years and up are pretty straightforward, as straightforward as it can be to get that imaging data on. And then, of course, we're expanding that all the way up through the adult range.
You know, in when we talk about ranges like that, one thing that I know you and I have talked about is, do we try to study individuals with severe Chiaris or mild Chiaris, or, you know, how do we try to understand the disease by studying just one end or the other?
Yeah, that is a tough one too. But it's also one of the more interesting parts of the project, that if we only ever studied the people with severe Chiari, then what value are we actually adding, right? If we only study the people who we know need treatment, we're probably not actually changing anything. So I think it's even more interesting to study some of those people at the other end of that spectrum, especially some of those patients that we hear about so often, who present to us with what imaging suggests might be a mild Chiari malformation because their tonsillar ectopia maybe isn't so severe, but their symptoms might be severe. And it's very interesting that there's the other side of that coin is we have patients who have significant tonsillar ectopia well beyond any kind of widely accepted cutoffs for what would define a Chiari malformation, that just by imaging looks severe, but their symptoms are mild, sometimes even completely asymptomatic. And how you kind of rectify that kind of cognitive dissonance is tough, but that's what we're hoping we're going to find in our functional connectivity data, is that if those patients who are more affected have significant changes in that connectivity, that might be a better metric than something simply structural.
It's interesting, you know, what we're really getting at is kind of the nature of this project, which is, are we really just talking about the degree of tonsillar ectopia, the cerebellum protruding into the top part of the cervical canal? Is it as simple as that? And I think we both agree, probably not. So to just have a sort of one measure, tonsillar ectopia, and to say severe or mild, probably doesn't make a lot of sense. You know, a person who's in the audience here with us right now is Gabe Haller, who's done a lot of work on looking at the development of this condition. And at least in some individuals, it's not just related to compression of the cerebellar tonsils. It may even, in some individuals, be more widespread, this condition. So that's one of the things I think so interesting about your technique with resting state, is you can sort of appreciate not just what's happening at the level of the cerebellum, but how it's affecting the rest of the brain.
I think that's exactly right. That's the part that gets me excited about it the most, is this funny little structure. These cerebellar tonsils have these huge implications. And like you said, it's probably something that goes well beyond what you can just see on a routine structural MRI. And that's the great thing about this combined project, is that while my focus is on this functional imaging, it's going to all go into a larger group that we're all studying slightly different things. I don't understand anything about what Gabe Haller does. Gabe Haller probably knows a little more about what I do, but in the end, we're going to put all of our data together along with all the other projects and hopefully redefine what Chiari is.
You know, the other thing that you said that I enjoyed hearing is you said that you can have a lot of tonsillar ectopia and relatively fewer symptoms, or you could have milder tonsillar ectopia and relatively more symptoms. And I was just talking to the fourth project in the group where we're starting to use machine learning to cluster how people present and their symptoms. Part of that work is being done by Sean Gupta, who's also here. And what we're seeing is the patterns are not all occipital headaches, or neck pain. We're seeing some people present with spinal deformity or, any number of other symptoms. I think that what we've always been taught is that Chiari is headaches, occipital back of the head, worse with a cough, and really brief. But certainly it seems more complicated than that. And I think maybe some of your studies are going to give us some insight into that.
Yeah, I hope so, because I had this conversation with a patient just this week in clinic about a Chiari malformation. And I said, of course, I'm a surgeon, so I always want to be able to tell you I can help you. But more than that, I want to make sure that I'm not going to hurt you. And so being able to identify which patients can benefit from the surgical procedures I do is a challenge. And I want to be able to help people. A lot of times what we do in clinic are telling people that you're not the right person for surgery. You're not a candidate. And this is something we worry about a little bit with Chiari malformation, is there's probably some patients out there who probably could be helped, but because they didn't fit into a very narrow definition of what we currently think of Chiari malformation, we might be missing out on helping some people that might benefit, that we just don't recognize.
I think that's right. And just to add one other thing to that is, if we do think about Chiari malformation as a disease that can have brain-wide implications, one of the other things I'm hoping to do with this study is to understand, if you do have brain-wide implications, what will respond to this sort of conventional treatment of posterior fossa decompression, and what will we expect not to. And sometimes that's really hard to kind of parse that out. The one term that people use across lots of different neurological conditions is this notion of brain fog. And so helping to understand that, which is really, I think, that's a term that's used for lots and lots of different things. Do you think that this can help us to understand what I would say as brain fog maybe, and I'm sure it has a million of different definitions, as sort of being some limitations in cognition or the application of your cognitive abilities to do one thing or another, or maybe just a little bit of confusion, or whatever the case may be?
I think that's exactly right. Brain fog is a very tough one to answer on a questionnaire. I can't give a questionnaire to somebody and tell them to rate on 1 to 10 your degree of brain fog. But that's one of the challenges for us, is to figure out how to capture those symptoms that they're describing. Because sometimes the best way they can describe it is brain fog. And for us, the challenge is to figure out how can we capture that, how can we quantify it, and once we can do that, how can we figure out what's contributing to that, whether it's tonsillar ectopia that's compressing at the cervical medullary junction, or if it's something completely unrelated. Right. That's one of the challenges for us.
And just to say it a little bit differently, if we can use resting state functional networks to understand the far-reaching implications of Chiari, then I think we will have done some good.
That's right, and that's why I mentioned kind of those canonical networks, default mode network or frontal parietal network. Those are some of those ones that might be implicated in things like executive function. That might be another term for that brain fog.
So Jarod leads our functional connectivity, which is essentially looking at brain network-wide effects of Chiari malformation, which is one of the 4 key areas that we're using through this program project grant. The others are certainly synergistic with that, right? Whether it's the developmental aspect that Dr. Hauer is working on, or is it other imaging tools that we're using with Dr. Straley and Dr. Song, for example, looking at really specific quantitative flow abnormalities, looking at strain and movement of the tissues, looking at micro histological changes in the brainstem, in the cerebellum, even as it stretches up into the rest of the brain, spinal cord. And then, of course, the last bit that we talked about is trying to put all these things together using advanced technologies to help us to understand this disease and how it affects brain development to a more certain level, and also to understand how, when, or why to treat. And so ultimately that's the goal. But I thank you. Your part is obviously a really, really critical part of that. And anyway, so I just have one last question for you. Why are you dressed so much better than me?
I wasn't doing any surgery today, so today was a research day for me.
Yeah. Okay.
So one of the studies that we talked about briefly was the Human Connectome Project. That was a cross-sectional study in mostly young adults. One of the evolutions of, as we learn more about the Human Connectome Project and how to better study these things, was a study called the ABCD, or Adolescent Brain Cognitive Development Study. That is a longitudinal study studying a lot of kids as they age. So it starts off at age 9 to 10 years old, and they follow them up all the way to, I believe, 18 to 19, maybe 19 to 20. They follow them all the way up to young adulthood. They re-image those same patients over and over again as they age. So a longitudinal as opposed to purely cross-sectional. The other thing that they hope to capture in that study is by first enrolling patients or research subjects who have no symptoms, no clinical diagnoses, no neurological conditions whatsoever, starting at that 9 to 10 years of age and going through young adolescence, those kind of teenage years where a variety of pathologies develop. Addiction, other kind of psychiatric disorders, headaches, migraines, a variety of things like that they'll capture over time. And they'll have essentially pre and post data as those things kind of develop. It turns out if you image a large number of people, you'll find a couple who have Chiari Malformation. It's not a large percentage, but it's a non-trivial percentage. The ABCD study enrolled 12,000 kids. So in 12,000 kids, you're going to catch a few that have the Chiari Malformation. Some of our good friends at UCSF were the ones doing those safety reads, and they were wise enough to prospectively record all those incidental findings. And so we now know of those 12,000s, which ones are purely normal, typically developing structurally, not unusual imaging controls, and which ones have a Chiari Malformation. Some of those have very significant Chiari Malformations, meaning their tonsillar ectopia is large, much larger than any of our kind of typical clinical criteria, yet theoretically they don't have, or yet at the time of enrollment, they have no diagnoses. They may or may not have headaches because they might not have come to a clinical presentation. Some of them might be suffering the symptoms of Chiari Malformation and just don't know it yet because they haven't reached that diagnosis. So that ends up being a very interesting population for us to study. It turned out to be a really great exploratory group for us to kind of devise our specific aims and our hypotheses for the study. And then we're using that same imaging protocol in our study. When we enroll patients who do have a diagnosis, who are symptomatic and present to us for treatment, we're using those same tools, the same imaging sequences, to replicate those findings that are given to us for free by the ABCD study, and taking advantage of the tools that were developed for that very, very large study to make our research much more efficient. Because we've seen that happen occasionally, where somebody who does not have a Chiari Malformation at some point in their time in their life, they weren't born with a Chiari Malformation, and at some point in time develop it. We don't have a very good understanding of the natural history of Chiari Malformation. We know it happens, that some people will develop a Chiari Malformation over time. We think some people are probably just born with it, become symptomatic at some point in time, but we don't have a whole lot of great data on the natural history of it. There might be some that's going to come from the ABCD study. I don't expect it to be a large number, but it will certainly be a very interesting data set to explore for that exact question. And certainly of those patients who theoretically are not symptomatic, or at least have not reached clinical presentation, we'll at least be able to follow them over their course of the ABCD study to see how their symptoms that they may or may not have evolve over time.
Thank you guys again for the discussion. Regarding the cerebellum, it's a part of the brain that traditionally we think of as more inert than a lot of other areas of the brain in terms of functional connectivity. Can you comment a little bit more on some of the emerging data and theories on how that integrates into the overall functional architecture of the brain?
Yeah, absolutely. So that was one of the things that spurred a lot of this work and there was a lot of functional imaging that helped define some of this, that traditionally speaking, people thought of the cerebellum as almost being purely a motor organ. Largely balance, coordination, motor memory type things. That's kind of what people understood about the cerebellum. As we've been learning more and more about it, we're finding that it has a large role in things like memory, things like attention, things like speech even. Some of that makes sense for us as pediatric neurosurgeons because we occasionally see these unusual syndromes, things like posterior fossa syndrome or cerebellar mutism that can occur after a posterior fossa tumor, for example. Very different than a Chiari Malformation, but it's a cognitive function that we wouldn't normally think of attributing to the cerebellum, yet is clearly affected by surgery on the cerebellum. So we knew that there was some missing link there. A lot of functional MRI data more recently, as we've gotten better at processing that data, has been showing us there's strong connections with all those tasks and all those networks that are known to be related to those higher order cognitive functions that appear in the cerebellum. One of the first conversations we had about this particular project was years ago when one of our project leads, Scott Merrick and Nico Dosenbach, published a really great paper talking about doing that precision functional mapping on the cerebellum and showing that some of those networks that you would not have normally thought about relating to cerebellar function were vastly overrepresented in the cerebellum. It didn't make a lot of sense with our traditional thinking of the cerebellum, but again, I think that's where our traditional thinking is probably going out the window as we're learning more and more about what the cerebellum does.
So how do you see activity inside the grooves of the brain?
Yeah, that's a fantastic question. It's one I really like because of the type of research I do. Functional imaging is one of them, and intracranial electrophysiology is another way. With functional imaging, it's the reason why I like it so much. It's very non-invasive. Anybody who can sit in an MRI scanner can get that data. And one of the things that we're able to do with, again, a lot of the tools that were developed out of Washington University, some of the Human Connectome Project work, is model the brain in its cortical sheets. And we can inflate that and see not only the crowns of a gyrus, but the depths of a sulcus. And we can model how that activity is being done all throughout that part of the brain. It turns out the brain itself is very convoluted. It has these deep folds in it. There's a variety of biological reasons why that probably happens. Some of that work was done here to explain how that folding happens or why it happens. But with functional imaging, we do some computational modeling to spread out that surface of the brain so we can see down deep in those folds of a sulcus to understand the brain, not just from what we as neurosurgeons see when we're doing a surgery, which is mostly the crowns of a gyrus, but all of that cortical mantle as it goes down the depth of a sulcus or deep into a fissure like the insula. And with some of that computational modeling, we can expand that and view the entire cortical sheet.
Well, Dr. Roland, thank you so much for joining us this afternoon. It's been a pleasure, and look forward to further discussion. We're probably going to do similar things with some of the leaders of the other projects, but I really appreciate you doing this with us today. Okay.
Well, thank you.